Welcome to the other side of Letby. In episode 73, we're going to look at a podcast put on YouTube by Dewi, who posts on my Pathetic podcast. But anyway, and she's got a great one here, which is an interview for the cross-examination of Dewi Evans by Benjamin Myers over the case of Baby A. So now we're going to show you just how many lies, deceits, ignorance, and catastrophic bollocks that this man, Dewi Evans, taught in this cross-examination.
Shall we move on to Baby A?
That is what I was hoping we would do. If I could, perhaps, before we go on. We will discuss in some detail. No, you carry on. We'll come to this, I'm sure.
We know that you've produced a number of reports with regard to Baby A, haven't you, Dr. Evans?
Yes.
I just want to be clear about some of the conclusions which you've presented in them, before we look at his case. In the report of the 31st of May 2018, which is the one we've been looking at principally this morning.
Let me open that up, please.
Yes.
Right. Yes, I've got that.
Your conclusion in that is that the collapse was the result of inappropriate therapy within a minute or two before the deterioration.
Something like that, yes.
Well, it's not something like that. It's paragraph 38, Dr. Evans. In my opinion, Baby A's demise was the result of his receiving inappropriate therapy prior to his collapse, probably within a minute or two prior to his deterioration.
Yes, his collapse. And the next sentence goes, his collapse is consistent with his receiving an air embolus. Yes.
Yes. You say that's consistent with an air embolus, and that is the rapidity of his collapse, is that correct?
Yes.
Very fast-acting indeed.
Yes.
Your view was that it was probably a bolus of air down the IV line.
Yes.
That is in paragraph 39.
Yes.
At this stage, before we get on to the other rubbish that Evans speaks, we have to look at the mechanics of this. This is the PICC line. This is the peripherally inserted central venous catheter. And it's running from either the arm or the leg, I don't know, but it's terminating in the right atrium. So this is going directly from the outside into the right atrium. And Dewi Evans told you there that the baby died. As a result of that, the baby died within 1 to 2 minutes of the air embolism arriving. So let's see how that actually stacks up against what the witnesses said. And we're going to look at the evidence of Dr. Harkness. So this is directly from Dr. Harkness' notes in the public record. So he says he inserts the long line at 1900 hours. He also said that he didn't think it was correctly placed at the time, but with his experience now, he does think it's correctly placed. But we'll not worry about that. Now, he also says that he removed it at 8:27. That's 2027. He says, it was my immediate thought in hindsight that there was no possible link between the insertion and the collapse. He said if the long line had moved further towards the heart, it could have caused significant increases in heart rate and other complications. He explains there's no evidence then or since to support that. And he also says that for Baby A, the heart rate fell to 60 to 70 beats a minute in the same minute. And then the public record goes on. The court hears that while air was getting into the lungs, unfortunately, no heart rate was detected at about 20:33. So we can tell that from the start of the infusion, which was 20:05, the heart continued to beat until 20:33, about 28 minutes, according to Dr. Harkness. But yet, Dewi Evans has just told us that the collapse happened within 1 to 2 minutes. So how does that work? Well, it doesn't. So let's track the error in the embolism from the moment it went in to the moment it had an effect. Now, the experts claim that the air was 5 ml, or a spoonful of air, and it's gone into this PICC line and it's exited directly at the right atrium. Now, the air now has 3 routes out of the body. A direct route through the right side of the heart into the pulmonary bed and out into the atmosphere, as well as being collected by the hemoglobin in the pulmonary bed. That's one route. So the oxygen component will be picked up in the pulmonary bed by fetal hemoglobin, and the nitrogen component, which is the bulk of it, is breathed out through the lungs over time. Now, the second route out is through the patent foramen ovale that we know that the baby has. And that will involve moving from the right atrium across the patent foramen ovale into the left side of the heart. And if it moves into the left side of the heart, it is in the general circulation of the output of the left side of the heart immediately. So where will the air embolism, the components of the air embolism, go? Immediately. It's in the left side of the heart. And we'll look at that in a minute. The third route out would be a combination of the two. So some of it went out the right side of the heart, into the pulmonary bed, into the atmosphere, into the fetal hemoglobin, and some of it went through the foramen ovale into the left side of the heart and directly into the left cardiac output, the main cardiac output of the heart. Now, if we take the first of these and assume that 100% of this oxygen dissipated through the right side of the heart, and we have Dr. Harkness telling us here that the baby's heart kept on beating for 25 minutes. Let's take the two components of the embolism, the two main components, which are nitrogen and oxygen, and look at what would have to happen to both of those components separately if they went into the right side of the heart. Now, there are 2 laws that are going to determine that. Remember, the bubble is free air in circulation. So it's a discrete entity in its own right. It's floating around, and the interface between it and the blood is the surface area of the bubble itself. The bubble doesn't have any membrane. It has no biological membrane. It's just a bubble sitting in liquid. Now, when the bubble enters into the body, it's entering into the body at atmospheric pressure because it's a bubble taken from room air. So the atmospheric pressure it goes in at is 760 millimeters of mercury, which is atmospheric pressure at sea level. Now we have to break that down into which components of the air contribute how much of the pressure, and that's why it's called the partial pressure. So you basically just add up all of the partial pressures to get the total pressure. So the total pressure is 760 millimeters of mercury, and there are 2 main partial pressures that we're looking at here, which is nitrogen, the biggest component, which is 79%, and oxygen, the second biggest component, which is 21%. So 21% of the 760 millimeters of mercury is 160 millimeters of mercury. So the oxygen component of the embolism has a partial pressure of 160 millimeters of mercury. Now, if we compare that to the pressure that it's sitting beside, that is the venous pressure of oxygen in the right atrium, we know that the difference between those two are 160 for the embolism and about 40 to 60, 40 mostly, for the oxygen tension or the oxygen fraction in the venous circulation at the right atrium. So we have a 4-to-1 gradient between the two, 160 to 40. Now that means that the oxygen is going to move from the area of high pressure to the area of low pressure. So Henry's law tells us, it's the principle in physics that tells us that the amount of gas that dissolves in a liquid is directly proportional to the partial pressure of the gas above or in contact with the liquid. And that means going into solution in the blood. It has nothing to do so far with hemoglobin. Henry's law only refers to the chemical dissolution of the oxygen into solution. Now, the next law that we have to look at is Fick's law, Fick's first law, Ficks. And Fick's first law determines the diffusion rate. That's the movement of the gases out of the embolism, depending on the surface area of the embolism, the thickness of the membrane between the embolism and the blood, and the concentration gradient, a bit like Henry's law. So if we combine the two of these, the effect of the two of these, we will see that the oxygen component of the air embolism will disappear completely into the systemic circulation and get bound up by hemoglobin in the systemic circulation within seconds, or at the very most minutes, 1 minute. Or if it remains trapped within the bubbles, that is, the oxygen remains trapped within the bubbles of the embolism, in whatever shape, size or form they are, they will neither go into solution nor will they interact with hemoglobin at all. Now, Fick's law will tell us that because the heart continued to beat, as Dr. Hart said, until 2023, and we also know from an unnamed nurse that she entered the ward at 8:15 at 2015, during which time CPR was underway. That means that Fick's law was in operation for at least 20 minutes between when that nurse witnessed the CPR and when Dr. Hartness said the baby's heart ceased. Now, the beating of the heart and the CPR, according to Fick's law, is going to break the bubble down into smaller components. And the smaller the components, the greater the surface area they will create, meaning that they will completely and utterly dissipate all the oxygen in that 5 ml air embolism, the spoonful of air, make it disappear, literally disappear, within seconds or minutes. So if the baby collapsed because of an air embolism, it collapsed because of an air embolism that moved into the left side of the heart across the foramen ovale and blocked the circulation that carried blood to the brain and to the heart. That's what would cause death, and that would be due to the nitrogen component and not the oxygen component. Because left-hand side of the heart, right-hand side of the heart, it doesn't really matter. Henry's law, Fick's law, will mean that the oxygen part of that air embolism, the 1 mil, 21% oxygen part of the 5 mil air embolism, is gone within 1 minute, either on the left or on the right, or a combination of the two. And therefore, if death occurred because of an embolism, it occurred primarily because the nitrogen component blocked blood flow to the heart and brain. But we have to remember that Dr. J. Ram and Evans and co. quoted the Neonatal paper and recalled 2 years later the pink flitting rash. And the pink flitting rash was said by them from the Neonatal paper to occur because of the direct oxygenation of hemoglobin adjacent to the free air. But there isn't enough oxygen for that, and anyway, it's already gone. The oxygen has disappeared. Dr. Jairam, according to the Court of Appeal document, arrived at 2023. If the CPR was ongoing at 2015, he arrived 8 minutes after, at the latest, 8 minutes after the baby collapsed. But at 8 minutes, sorry, Dr. Evans, there is no oxygen left in the air embolism to cause direct oxygenation of hemoglobin in the skin, meaning that the pink flitting rash which Dr. J.R. had seen had nothing whatever to do with a venous air embolism. So, Dr. Evans, you can have it one way or the other. You can have it that the baby did die of an air embolism, but the timelines sadly don't stick together because death would be relatively instantaneous within 1 to 2 minutes. But you cannot have the pink flitting rash caused by the same phenomena. And that's where J.R. and all the rest of them really messed up. They didn't understand that the Lane Tanswell paper was referring to the continuous supply of oxygen through a ventilator into the circulation of the baby. In the pulmonary vascular air embolism that they were describing versus the discrete and singular administration of a venous air embolism that they accused Letby of. So which of the two are you going to drop first? The air embolism itself or this amazing pink flitting rash? Because according to physiology and the laws of nature, you can't have both. You have to pick one because the oxygen is gone. And to make matters even worse for you, the cardiac output to the skin in a baby is less than 5%. So even if all of the oxygen component of this air embolism, the 1 mil oxygen component of this air embolism, did reach the skin, only 5% of it would. The rest would have been picked up along the way by other organs. And if only that much reached the skin, again, it can't produce a pink flitting rash. But what could produce a pink flitting rash or the perception of a pink flitting rash is either a made-up story, skin manifestations of collapse from any cause, the lighting in the room, or anything else that you might want to make up. But you can't have both. You can't have the pink flitting rash and the air embolism. And because the baby collapsed and died suddenly, and you no longer have a pink flitting rash to associate with that event, then the baby's collapse could have been due to many other things, which we will now go on to explain from Dewi's own evidence.
Now, you've explained how this is all based upon babies who were stable before collapse has happened.
Yes.
Just reminding ourselves where baby A is concerned, we know he was very preterm. 31 weeks and 2 days, wasn't he?
Yes.
And 1.6 kilos.
Yes.
So, low birth weight. And I think you acknowledge there are inherently problems that preterm babies face that can make them quite fragile.
Yes, I have heard that term. I don't think I've ever described a baby as being fragile. I think they're at increased risk. They are dependent. Fragile is too emotive for me as a term. It's not one I've ever used, I don't think, in relation to babies.
They are prone to complications, aren't they?
That's why we have neonatal units, yes.
That's right. They're prone to complication, aren't they?
Yes, yes.
Now, to look at what you say about baby A and his starting point in this case, it's a sad fact that he lived for barely 24 hours. That's right, isn't it?
Yes.
And so when we are considering the problems that he encountered, do you agree we need to keep in mind, sadly, how short the timescale is that we're working with?
Yes, yes.
And in a timescale like that, there isn't a great length of time for serious problems to make themselves obvious, is there?
The fact that he was as stable as he was, prior to his collapse, meant that he had survived the most perilous part of his life. And in other words, yes, so by the time that he was just prior to his collapse.
I wonder if I could just ask you, you've explained that. I wonder if I could respond to what you say about him being stable, because that's what I would like to ask you about, Dr. Evans. And I would ask you to help the jury with.
Yes.
When you were dealing with the question of how stable baby A was to start with, began by saying, I have said his condition was perfectly satisfactory. It's better to say he was stable.
Yes.
Just so the jury can unravel what that means. In your reports, you began by saying baby A was in a perfectly satisfactory condition, didn't you?
Mm-hmm.
You accept now, do you, that that's probably pitching it a little bit too high, isn't it?
No, I think, I don't want to get engaged in semantics here, but if you want to stick with perfectly satisfactory, I would say he was perfectly satisfactory for his position at the time. In other words, for a baby of his prematurity, aged 24 hours, his condition was satisfactory. If you want to make me look perfectly satisfactory, that's fine, but he was really good.
So Dewi doesn't want to engage in semantics, but he uses the word perilous to describe an emotional journey for this baby. So perilous is okay to use, but delicate is not okay to use. And we can see here just the complete bias of this man, that he wants to avoid anything that will, in the slightest, throw doubt into the mind of the jurors. And he's prepared to even argue with himself by using semantics. To do that, he will use any weapon, anything he has available to him, he is going to use to give a completely biased report and completely inaccurate report about what happened to baby A.
You agree? When he was born, he needed rescue breaths before he was taken.
He did.
His rate of breathing was poor immediately after birth, and he needed inflation breaths, didn't he?
Yes.
He was all right after about 4 minutes.
Yes.
By 9 p.m. I can go to the notes if you need them, but by 9 p.m. on the 7th, there were pauses in his breathing when he wasn't being stimulated, yes?
Yes.
That's a potential problem, isn't it?
And the answer to that is yes, it is very much a potential problem.
Irregular breathing patterns are very common in premature babies. It's something that one deals with on a regular basis, and it's not a cause for concern in a baby unit because they are on full monitoring.
Translation: aircraft crashes are a fairly common event, and because they happen in the sky, we don't need to worry about them.
He was on, in fact, CPAP, wasn't he? To prevent the airways from collapsing.
At the beginning he was, yes.
If we look at the clinical notes, please, they're at slide 84 and it's page 1062. It's slide 84 in the baby A profile.
1062.
1062.
I've got it.
It will appear in a moment, the ones in front of you. It's coming on. Thank you. If we just look at the top of that, please, Dr. Evans, just to give us an idea of where we are on the morning of the 8th of June 2015. Perhaps we can enlarge under where it says problems, Mr. Murphy.
All right. Preterm.
Can we just let everybody see it, Dr. Evans? If we just look at the top, this is the note from the clinical record saying problems, preterm, which is in itself a problem potentially, isn't it?
Of course it is.
RDS, that's respiratory distress syndrome. That's a problem potentially.
Yes.
Establishing feeds. That's a problem. Suspected sepsis at this point.
Yes.
And it's got maternal antiphospholipid syndrome. And we are going to hear more about that, and that's not something I'm focusing on in these questions. I'm not suggesting that's the issue here. But certainly at this point, there are legitimate concerns as to his progress, aren't there?
No, there are.
No, there aren't, says Dewi. He must be the only person in the world that believes that the extensive list that Ben Myers has just read out, are not serious or potentially serious problems for a baby who is less than a day old, born at 1,600 grams and 32 weeks or 30 weeks gestation, making Dewi's evidence unique in the history of neonatology. Yet another first for the Letby.
These are, I'd rather call them issues rather than problems, but let's not get into semantics. This is what any competent junior doctor would list as the issues facing baby A at the time he arrived in the neonatal unit. In other words, we've to deal with the fact that he's preterm. We have got to deal with the fact that he might have breathing difficulties. We have to establish his feeds because his sucking-swallowing reflex isn't mature. He's at risk of suspected sepsis. And then there is this unusual condition of maternal antiphospholipid syndrome. By the way, I don't want to get involved with the antiphospholipid syndrome because I know there is a hematologist who knows far more about this. And this is outside of my expertise.
We're not raising any issue with that as it happens in any event, as I just said.
So therefore this is For any baby of 31 weeks, the doctor would write these things down.
Now, if we just look at slide 32, it's a little bit before this. The clinical notes at slide 32, page 1061.
1061. Yes.
We will just wait for it to come up on the screens, Dr. Evans.
Yes. I'm relying on my own.
That's all right. If we scroll down, we can see an X-ray review.
Yes.
If we look at that just before 1 in the morning on the 8th of June, Dr. Brunton, and it says RDS type picture.
Yes.
So this isn't just something that's being written in the notes as a formula, or something any competent clinician would say. We have got here from an X-ray something which is certainly consistent with respiratory distress syndrome, haven't we? On the X-ray.
I have seen the X-ray. I have seen the report. There's nothing, it's not too bad actually.
It's the sort of thing which might lead to some difficulty with breathing though, isn't it? RDS.
This is why we put babies on CPAP.
But, in terms of where you're saying he's stable and whatever, just look at the various factors.
No, this is at
0:45 in the morning of the 8th of June.
Yes. So he was born at 8:30 p.m. Yes, 4 hours old. He's 4 hours old. This is the X-ray at 4 hours. My comment regarding stable relates to him at 23 hours of age.
So now Dewi is going to sell us a yarn, or try to sell us a yarn anyway, that the baby may not have been stable at 4 hours, but he is going to become stable over the next 20 hours or 19 hours or whatever number he wants to say. The baby he's referring to is not the same baby at all. He is a different baby who is not clearly stable at this point because he has all these things that Benjamin Myers has listed, but they're magically going to disappear in the next 19 hours, is what Dewi wants us to believe.
We know we've got blood gas readings up to as far as they go, and they are tile or slide 29, page 1125. So let's have a look at that, please.
1125.
Slide 29 for those of us on the iPads.
Yes.
Just enlarge the top half so that we can see that, Mr. Murphy. If we look down there, this is moving forwards now. We've had the X-ray just after midnight on the 8th. If we look at 6:37, look across to lactate. That's on the high side, isn't it?
2.6. Pretty marginal. Again, from a clinical point of view, it's very important to look at the whole picture. Therefore, if you have a whole load of blood tests, 1 or 2 might be slightly outside, accepted, the norm. 2.6. So it's over 2.
Yes, and at, what is that, 2:30? It's risen a bit more to 2.7, hasn't it?
It's the same.
Would it not bother you if you were looking after a baby to see the lactate increasing above the recommended range?
Not particularly. Well, it's not. Let's look at the whole results. Okay, for 14-13, I think they are.
Yes, 14:30. So that's 2:30 in the afternoon. And this baby is now 18 hours old. So around about 18 hours, and we have one set of blood tests, which are a capillary blood test, and that is the level of data that we have gathered on this very sick baby. And this is the amount of data that this man, Dewi Evans, is now going to claim proves that the baby was stable.
You've got a pH of 7.37, spot on normal. You've got PCO2 of 5.15, spot on normal. It's a capillary gas, so you can't interpret the oxygen level. It's 4.66, but you can't interpret that.
Is a little low, isn't it?
No, you cannot interpret that. Okay? You cannot interpret.
Why is that one not interpreted? It's low, isn't it?
No, it's not. It's a capillary sample. You can't interpret it. All right? Listen.
So Dewi is going to tell us that the baby is fine by using 2 methods of assessing the oxygenation of the baby, both of which, or neither of which, are reliable. These oximeters have been shown in studies to overestimate arterial oxygen saturation by as much as 3 to 6%. So They have failed ISO or International Standard Organization tests on multiple occasions and have multiple drawbacks. So they are not reliable in this situation. And we are using another method, which he says he is not going to read because it's not reliable either. So what Dr. Evans has really said is that we're nursing this stable, unstable baby, whichever way you want to look at it, using two methods to measure the oxygenation of the baby, one of the key components that we're supposed to be measuring, neither of which are reliable.
Then you've got a bicarbonate of 22.3, which is normal, and a base deficit of 2.5, which is, less than 5, which is fine. So therefore you've got this blood picture, and you have a glucose, by the way, of 5.5, which is again normal. Therefore you've got 1, 2, 3, 4. You've got 5 normal tests, and one that is on the margins of being slightly up a bit.
Just so the jury follow.
Just a minute. And then in addition, and I'm sure we'll come to this, in addition to that, even more usefully I think, we've got this constant monitoring, heart rate, oxygen saturation, and they are also normal, and, as Dr. Bohin said earlier, he's handling well.
We are going to go there. Don't worry, Dr. Evans.
We'll go there.
Can I just check? With oxygen, the standard range is 7.5 to 10, for blood gas, isn't it?
For an arterial sample, you would like it to be more than 7.
More than 7.
More than 7. 8, 9.
10?
11. 12.
Right. You say you don't really count this because it is from a heel prick.
Yes.
In any view, the oxygen is dropping from what it was at 637, isn't it?
As I have said, I am not going to interpret an oxygen value from a capillary sample.
Okay.
Let me say that, for all babies, for all times, I'm not going to do it.
But what Barry is not going to tell us, but which he should have told us if he was really an expert, is the lactate paradox. So if the baby has certain problems with metabolism, it means that it cannot make enough lactate to elevate it. So paradoxically, a normal or a slow rising lactate in a metabolically compromised infant doesn't exclude hypoxia. And we don't have enough information on this baby to know what its true metabolic state is. And with regards to the capillary blood gases that he's not going to pay any attention to, a consistent downward trend in capillary oxygen, example from 60 millimeters of mercury down to 40 millimeters of mercury, does signal deteriorating oxygenation. Even if the absolute values are inaccurate, the trend is down. That means that the baby's not getting enough oxygen, no matter what he says. And sometimes when all you have is a capillary reading, that is what you have to go by. So Dewi Evans is wrong to say that you should not act on a falling capillary oxygen measurement when you have a concomitant elevating lactate, no matter how small that lactate elevation is. You have two components, both of which aren't accurate, but two of which are moving in a negative trend.
We don't have any readings, do we, as we get to the period we are most interested in? In terms of, sadly, the deterioration at about 8 o'clock?
We do, actually.
Do we have any on this chart?
No.
You tell us where the readings are.
On the neonatal...
Are you talking about the respirations and heart rate and things like that?
Yes.
So Dewi is now going to tell us and confirm for us that this baby had its last blood gas analysis at 2:30 p.m. 2:30 p.m. That is 6 hours before the baby died, when we have it in such a perilous condition. That is one of the most gross acts of negligence that anyone can perform when looking after a baby that's as delicate as...
I'm going to that. I'm talking about blood gas readings, Dr. Evans.
Sticking a needle into a baby's heel hurts, so you can't do it every few minutes or so. So therefore, it's done quite frequently in this particular case, which is fine. That's not a criticism. If I saw these gases at 1400 hours, 2 p.m., and my baby at this time was in air. I would not be rushing to stick needles into that baby anytime soon unless there was a change in his condition. That is what we call good clinical practice.
Sorry, Dewi, that's not what you call good clinical practice. The clinical guidelines are that the blood gases must be checked every 2 to 4 hours in a situation like this, and likely more frequently because of the elevated lactate. So that's why the baby's in a neonatal unit, so that you can avoid testing the blood gases to tell ahead if something is going to happen.
Let's take a look at 1123, please, which is the observations chart.
1123.
Provided on that.
That's the one I was talking about.
We will come to that in a moment. That is slide 28 I've got down, but they appear in more places than one. So slide 28, if we could put that on, please. We can see. Let's just increase the size in the yellow sections, please, Mr. Murphy. We're familiar roughly with what we're dealing with here now. Yes, you made reference to what Dr. Bohin said before lunchtime. She said it was stable and not escalating. That's her words, not escalating.
Correct.
The respirations on the chart, what we see.
Let's go through them from the top down. That's the easiest way.
I think it would be better if you're actually asked a question and you answer the question rather than just speaking to the document.
I would be grateful for that. Let me direct the question, Dr. Evans, to assist with what we're looking at. We're talking about stability, right? And you made reference to Dr. Bohin. I made note of what she said, which was extremely stable, not escalating. Now, if you look at the respirations, first of all, please, those are not extremely stable, are they?
I disagree. Because his respiratory rate is in the yellow bit, it's higher than the accepted normal range. It's 70 plus rather than 60, 50 or 60. But if you have any feature that is outside the normal range, you need to find out what the probable cause for this is. And you need, as in every case, you need to interpret one individual criteria, marker, in relation to everything else. So what we've got here, if you look at the respirations there, right from the beginning. So in the first third, they are all in the yellow, if you put it that way. And somebody has written down there, unsettled, I think. And then it falls to about 60. And then from, 11 noon, from noon, it toodles along at about 70.
Well, it's escalating in the afternoon, isn't it?
It's higher than it was. But there's a perfectly good explanation for that.
It's all stable. It's all in the yellow patch, isn't it?
Yes.
Why is it yellow, that bit?
There's a perfectly good reason for that.
Well, what is it?
Well, the doctors have been fiddling around with him, putting umbilical catheters in.
Why is that section yellow? I wasn't clear. Why is it yellow?
I think he was giving you a perfectly good explanation.
I apologize.
He was giving you the explanation for it, I think. I'm not the witness.
If you go through the medical notes, medical charts at this time, you will find that the doctors are doing what they can to, make sure this baby stayed stable. So they have been putting umbilical catheters in. It's ended up in the wrong place. Nobody's fault. It happens. Then around 6 o'clock, from what Dr. Harkness said, they put an IV line in, a long line in. Sticking a needle in anybody's vein hurts. It's uncomfortable. You're handling the baby. Therefore, all of this will make anybody, not just a little baby, a bit unsettled, so therefore his respiratory rate goes up. So what's important in clinical practice is that if you've got a feature that's outside the normal range, that you find an explanation for it. And there is an explanation for it. This baby was being handled, quite correctly by the way, but it meant that he was being fiddled around with because of the difficulties with cannulas, and then getting the IV line in. So there we are. So that in itself is an explanation, but even more important, all the other markers are normal or stable.
So I think that might have been Justice Goss jumping in there to speed things along, I don't know, or help Dewi Evans out because he's kind of withering a bit. But let me put them both right. In managing a preterm infant with respiratory distress syndrome, suspected sepsis and a slowly rising lactate level, and the baby is on nasal CPAP. Attributing persistently elevated respiratory rates solely to medical procedures is not considered good practice, because multiple overlapping factors typically contribute to respiratory distress in this context, and a comprehensive assessment is critical. So let's look at the critical evidence-based analysis of what that comprehensive assessment should look like. We need to reevaluate the CPAP settings. Consider using more surfactant, which I haven't heard mentioned yet. Investigate the sepsis, that is, do a proper workup, including a lumbar puncture. Start empiric antibiotics. I don't know whether we've done that yet. After we've done blood cultures, and I don't know if we've done that yet. Look for thrombocytopenia, that's falling platelets, temperature instability, or hemodynamic changes, that's blood pressure. But we've no way of measuring blood pressure accurately in this baby in our level 2 units. And we have to keep assessing the lactate trend, which we have now stopped doing at 2:30 p.m. We have now stopped measuring the pH, and we also need an echocardiograph to tell us whether or not we have ductal shunts still open. So that's a patent ductus arteriosus, which is an old part of the baby's circulation that works in utero and can persist outside, but will shunt blood away from the left side of the circulation. And God forbid, we might even attempt to do an arterial blood gas, which will actually tell us what the oxygen is available to the baby. And whereas the procedures definitely would cause the respiratory rate to go up, they are not likely to do that on a persistent basis. They will do it at the time of the procedure, but they will not continue to do it. They will not continue to rise, that is, if the baby is truly stable. Again, it's the persistence of the elevated respiratory rate that is the problem. Not the elevated respiratory rate in itself, but its persistence. That is pathological, not procedural. Or at least that is what you would have to assume. And in the absence of the critical data here, you would definitely have to assume that.
Now, do you agree, first of all, the respirations are at least elevated for almost the whole of that period, Dr. Evans?
Yes, they are.
Do you agree that they move down, they move up?
Yes, they are.
So the first thing is you agree, as we look at it, that is not steady. It's not at one level, is it?
It's variable.
Do you agree, as we look at it in the afternoon, it is escalating? Yes or no? Tell us if you don't. We can see it. What do you say?
It's gone up. It's moving between 75 and 80.
There isn't a lot of chart left, is there?
It's not escalating.
So it's gone up. It's gone up, but it's gone escalate, but it's not escalating.
Do you agree that when it goes onto the yellow, that's done because it draws attention to something that might be a problem?
In isolation, I don't think you can make a diagnosis from an isolation. I don't know what we're getting at, but you've got an isolated increased respiratory rate in a baby who is preterm, and everything else is nice and normal.
Do you agree that his respiration goes up? You might expect ordinarily heart rate to go up together with it.
Yes.
His heart rate doesn't go up, does it?
No.
That's odd, isn't it?
No.
You have just said you would expect it to go up, and now you are saying it is not odd.
I would expect the heart rate to go up if, let's rephrase that. If his heart rate had gone up as well, then I would be concerned about the baby.
We have Dewi, who's actually arguing with himself, but he's saying that if the heart rate had gone up, but we're not talking about a situation where the heart rate has gone up. So he's actually given evidence about a hypothetical situation.
I would be concerned that he was then not stable, but in fact his heart rate is about as normal as it can be. So therefore heart rate is a very, very good marker of well-being in a little babe. Therefore we have got this increased respiratory rate in isolation. Am I worried about it? No. Why am I not worried about it? Because he was in a neonatal unit with experienced nurses and doctors to look after him, And on top of that, he's not even requiring additional oxygen. And that, for a prem baby, coming up to 24 hours of age, the fact he's able to breathe without additional oxygen and his saturations look at 97, 98, 99%, that's about as good as it gets.
And so we have to correct Dewi yet again. Blood gas readings, even by oximetry, of 97 to 99% are considered unsafe in preterm neonates because these levels correlate with arterial oxygen tensions of over 80 millimeters of mercury, and that exceeds the physiological need and promotes free radical damage. So if you add too much oxygen into the formula, they create these things called reactive oxygen species, which will tear delicate cells apart. So the 99% oxygen is not a good sign. And we're in a complete mess now because we have an elevated respiratory rate with elevated oxygen, according to Evan. And the reasonable conclusion to come to about that is that we're now compensating for acidosis internally. So if we're speeding up the respiratory rate, not because we need more oxygen, we're doing it because we need to blow off carbon dioxide. And we need to blow off carbon dioxide because carbon dioxide is acidic. And when we blow it off, we blow off the metabolic acidosis that's building up underneath it. And the big suggester of that is the elevated lactate, which he continues to ignore. So now we need to stick a needle in the baby. We need to know, not at 2:30, but now at 4 o'clock, 5 o'clock, 6 o'clock, whatever time, we need to know what the pH is of the blood. And if the pH of the blood is okay and we continue to allow the baby to blow off too much carbon dioxide, we're going to risk creating metabolic alkalosis. That is, we're going to allow the pH to drift upward. And if we do that, we're going to start to move around potassium in the blood of the baby, near the cells, in particular the cells of the heart. And since the potassium is used to charge, to put an electrical charge into the contractile muscular of the heart before it contracts, we're going to risk throwing that into complete chaos and creating an arrhythmia. And an arrhythmia would be enough to stop the heart. So at this point in time, we desperately need an arterial blood gas, and we desperately need to know what the bicarbonate level is, the pH level is, the base excess is, and what we're doing instead is fumbling about in the dark, trying to rely on physical signs alone, which is not why you have a baby in a neonatal unit. You have them in a neonatal unit because you have access to the other technology that will give you more data to make the decisions you need to make.
Do you say it was good that he hadn't had, I don't mean good for him, but was it clinically acceptable that he hadn't had fluids for at least 4 hours, and maybe longer by the time?
It's not good. It's not good.
Is it acceptable?
Well, it happens. This happens in neonatal units. This is the way of the world. And I think I discussed this morning. Nobody would want a baby to go without fluids for 4 hours. Did it make a difference in his case? As I discussed this morning, no. Why do I say that? Easy. If he was experiencing fluid loss, then, as we know from patients who are admitted with fluid loss, the heart rate goes up. His heart rate didn't go up, so it's unfortunate, but it is not something that it wouldn't be. My word, we are all going to get COVID in a minute. Where are we? I'm getting distracted here.
Let me help you. What I would like you to help us with is this, Dr. Evans. Is there a possibility that there's a problem for him not to have received the fluids he was meant to have received for a period of, and the blood sugar, for a period of 4 hours? Is that a potential problem? That's what we need to know.
His blood sugar, the most recent blood sugar they took was 5.5, which is great, which is fine. That's fine.
That was about 6 hours before the collapse, wasn't it?
Yes.
Yes.
A blood sugar. Sorry.
Just to assist you, Dr. Evans.
Excuse me. I'm being distracted by loads of people coughing. Just a minute. So he lost 4 hours worth of fluid, which I think he was on 4.15 milliliters an hour. So he missed out on a theoretical 16 milliliters of fluid, now of 10% dextrose. And 16 milliliters of 10% dextrose contains 1.6 grams of glucose. And 1.6 grams of glucose contains 6 calories. So a baby who has lost out on 6 calories is not going to drop a glucose value from 5.5 to a level where he crashes. This baby did not have a little twitch or anything like that. He crashed to the extent he died. So, sorry. Let me finish this bit. So therefore it's unfortunate that he did not receive IV fluids for 4 hours. He did receive some oral fluid, by the way, 1 or 2 milliliters, which is better than nothing.
That's no substitute for failing to get the IV fluids, is it?
No, it's unfortunate, but in this particular case, it did not make a clinical difference. And that's the important point I need to impress.
Going without fluid for the 4 hours is capable of causing dehydration. Do you agree or disagree?
Of course it does.
And also, going without the glucose that he was meant to receive for 4 hours is capable of leading to or triggering hypoglycemia, isn't it?
Yes.
In a child which we know is now tachypneic, which is breathing too fast.
Yes.
But you don't see any of that as being a potential problem. Is that your evidence?
It's not so much that I don't see it as a potential problem. From the records I have seen, it was not a potential problem.
We don't know that, do we, Dr. Evans?
Yes, we do, actually. Yes, we do. This baby was in air, his saturations were 99%, his heart rate was nice and steady at 130, 140, and his temperature was fine. So we have got loads of markers here of a stable baby. And I heard Dr. Harkness say he was absolutely devastated by the baby collapsing because, and Dr. Jayaram the same, this was a baby who was stable prior to his collapse. Their words, not mine. Their words, not mine. But I'm just looking at these records and, yes, the respiratory rate is tachypneic. Yes.
So let's just correct Dewi again here for the sake of posterity and look first of all at the calories. So the calorie loss, 6.6 kilocalories, that's 1,000 calories, not calories, from a 4-hour interruption of 10% dextrose at an infusion rate, he said, of 4.15 mils per hour is mathematically accurate, but it's misleadingly low in clinical terms, and I'll tell you why. So 10% dextrose equals 10 grams of glucose per 100 mils, or 0.1 gram per mil. So the infusion rate deficit for a 4-hour deficit would be 0.415 grams per hour, multiplied by 4, 1.66 grams of glucose, giving us a calorific loss of 6.64 kilocalories, 1,000 calories, not calories. So why does this matter? Well, the hypoglycemic risk, obviously, is the big concern. A preterm baby requires 4 to 8 milligrams per kilogram per day of glucose to prevent hypoglycemia. That's just to prevent hypoglycemia. For a 1.6 kilogram infant, that equates 6.1 to 12.2 grams per day. For a 4-hour deficit of 1.66 grams represents 14 to 27% of the daily needs. 14 to 27%. That's how easy it is to minimize these things when you don't want to give honest evidence. And that 14 to 27% deficit of glucose needs is not taking into account the work of breathing, which has been up for at least half the day. Then we put in the compounding factors, because there are always compounding factors. The sepsis, the tachypnea, the respiratory distress syndrome. It all of a sudden starts to look a lot more consequential than Dewi's OLED just took away 6 calories. We're chucking away 4 hours, at least 4 hours, and probably longer. Meaning we're upwards on 25% deficit in calories per day. Let's look at the fluid deficit. So if we assume it's only 4 hours without fluid, that's 4.15 mils, which is what they were giving them, not necessarily what the baby needed, but what they were giving them. By 4 hours is 16.6 mils. We know from somebody else's evidence that there was a urine output of 25 mils, but that was measured, I think, around about 5 o'clock, so there was probably more, but we'll take 25. Normally, a baby will lose at least 1 mil, 1.5 mils an hour. And then we have to calculate what's called the insensible water losses. And the insensible water losses are the water losses that occur through the breathing and through the skin. And they're always made worse, a lot worse, by the use of CPAP. So for a baby on CPAP, they're going to need upwards of 80 mils per kilogram per day. So 80 mils multiplied by 1.6 kilograms is 128 mils a day, or 5.3 mils an hour. And over 4 hours, that gives us 21.3 mils deficit. So if we add all of that together, we have the 16.6 maintenance loss, plus the 25 mils urine loss, plus 21 mils insensible loss. We now have a 62.9 mil deficit, which is significant. Now, why might we worry about that, particularly in the case of the baby who has MPS in the mother and who has an unused, sitting there doing nothing except gluing itself to the side of the wall of the post-vein umbilical venous catheter? Why might we worry about this played down insignificant fluid deficit, which, if we go by body weight, assuming that body weight is 80% water, the body weight of the baby at 80% would be 1,280 mils of water. So the deficit is upwards of 5% of body weight. We're going to have to worry about a thing called the hematocrit. Now, the hematocrit is a measurement of the difference between the solid components of the blood and the liquid components of the blood. And obviously, the more liquid we have, the more the blood will flow, and the less viscous or sticky it is. So the higher the hematocrit, the more sticky the blood, just to keep it simple. Now, we know that we were told by Sally Kinsey that the baby had a normal full blood count for gestational age of 30 weeks, just 2 hours after birth. So a normal hematocrit for that gestation is 45%. Now, if we do delayed cord clamping and we allow more blood pool in the baby, it will be higher than that, but we don't know that, so we have to go with 45%. So the hematocrit will rise as the plasma volume, the amount of liquid in the plasma, decreases. And we don't want the hematocrit going over 50, because if the hematocrit goes over 50%, we have produced hyperviscosity or thicker blood, more likely to clot. And if we do the calculation on this baby on the best terms, that is the 4-hour deficit of fluid and the losses, the insensible losses that we've talked about, we are going to increase the hematocrit from about 45% to about 47%. But these are calculations. The hematocrit is going to go up anyway. It's certainly not going to go down. And for every 1% that the hematocrit rises, we increase the risk of clotting inside baby A by 10 to 15%. And for every 5% it rises by 50 to 75%. So because of the unique nature of baby A, all of these accumulating problems are much more relevant for this particular baby than they might be for a general baby in a neonatal unit who might get away fluid-wise with 4 hours of a deficit, but I doubt would get away calorie-wise with that long a deficit, because babies of the 30 weeks cannot make new gluconeogenesis. They can't do it very well, and they get hypoglycemic. About 40% of babies get hypoglycemic anyway. They don't need any help. by not giving them glucose for 4 hours or more.
I'm going to avoid repeating questions I ask, to say where we disagree. That would be clear from the questions I'm asking, and I'm going to move on so that we can get through the evidence. Do you accept there is a potential risk of arrhythmia from the position of the long line? In other words, is there a potential risk that it could have been sited too close to the heart and created some sort of problem?
Not in this case, no.
Do you see that there's any obvious link in the relationship in time between long line insertion and then fluid running through the long line and then collapse?
No. I'm not sure that question what you mean. Long lines are routinely used. Fluids running through a long line does not cause a baby to collapse.
Do you recognize, or do you accept, there's any risk involved in leaving a long line in place without fluid running through it for up to 2 hours?
No, there would be fluid in it.
Running through it, I asked.
Not running through it. Right. If there was... Right.
Can I ask the question, and then you can by all means expand upon it if you need to, Dr. Evans. But what I asked was, is there any risk caused by leaving a long line in place without fluid running through it?
There's a risk of the long line clotting.
Tamponade. You have explained that's where fluid gets into the gap between the heart tissue and the external sac of the heart, the pericardium.
Correct.
When you made the report that you have been looking at, and you were dealing with the question of tamponade, and you deal with this at paragraph 36 of that report, page 752. What you say, Dr. Evans, is that cardiac tamponade is a complication of long lines. It typically occurs in a baby where the line has been in place for some time, probably 24 hours or more. This would not occur within minutes of insertion of a long line. Just to be quite clear, did you think it had only been in place for minutes when you said that?
Well, I'm not quite sure, but it didn't look within a couple of hours anyway.
It could occur. You say it couldn't occur within a couple of hours. Couldn't.
No. Let's forget about tamponade. If there was tamponade there, it would be present on post-mortem.
I just wanted to see why you say minute.
Have to correct down there again. Now remember, the baby has gone 4 hours or more without any dextrose. And what do? They put a hypertonic, concentrated hypertonic solution, 10% dextrose, into the PICC line directly into the heart. So this rapid infusion of this hypertonic solution of dextrose into the heart can and has been recorded as causing hypokalemia or low potassium in the locality of the heart where the dextrose is arriving, and the release of insulin into the circulation will drive that dextrose into the cardiac cells which are hungry for it, which can also drop the potassium level, particularly in the region of the heart. So, prolonged hypoglycemia or low blood sugar, followed by a rapid correction with 10% dextrose, can destabilize myocardial cells. And there are case reports of this happening, so it's nothing that I made up. And the particular problem it causes is a prolonged QT interval or torsade de pointe. It's actually got a name. So the QT interval is the time it takes the heart to depolarize and repolarize. In other words, to discharge and recharge. Now, if that gets messed up, we have a part of the heart called sinus node, which is a specific part of the heart which tries to keep the rhythm of the heart regular. And it's going to keep firing away signals to tell heart cells to contract, in other words, to depolarize. But if they're not in a position to do so because the QT interval has been elongated, in other words, if they're not ready to discharge but they're getting a signal to discharge, they're going to partially discharge. And if you do that enough, you're going to get arrhythmia. And arrhythmia will lead to arrhythmia. And none of that will show up on a postmortem. But yet, there are case studies that show that it did happen. And also, there are other case studies that show, and I've talked about this before, that mechanical irritation of the PICC line in the heart without causing any damage to the heart. Just the fact that it's irritating the endothelium or the lining of the blood vessel in which it's sitting, that can cause arrhythmia as well and will not necessarily show any problems at postmortem. But to pick all of this up, you also have to have a 6-lead or full-size ECG measuring the heart at the time. A 6-lead ECG is not the same as a smaller 3-lead ECG. So these infusions can mess up the QT interval. And if they mess up the QT interval, they can cause arrhythmias. So it's quite possible that once that 10% dextrose flooded into the heart when there had been no glucose there for quite a long time, 4 hours or more, that it caused the cascade of repolarization, depolarization, mismatch, and led to an arrhythmia that would not show at postmortem. So Dewi's throwing in a red herring here, talking about tapping at. Why is he talking about something that didn't show at postmortem? We're not interested in things that don't show at postmortem. We're interested in things that do show at postmortem. But he's trying to get over to the jury that this line could not have caused a problem to the baby, and it could, either one of them, the unused UVC or the currently running PICC line. And what effect did the infusion or the sudden infusion have on the tip of the unused line? We don't know. And that's the type of evidence that I would consider that a real expert would give.
Infection. Do you accept there are potential...
I just want to get a note there. Thank you. Carry on.
Sorry, my lord.
No, it's fine.
Do you accept that there are potential signs of infection or developing infection from what we can see in the observations and the blood gas and the picture presented by Baby A?
No.
You don't regard high respiration as a possible indicator of it?
Well, again, 2 things. It's an isolated sign, and secondly, there was no evidence of infection on post-mortem.
It's entirely possible, in a fast-developing infection in a small child, for it to develop and leave little by way of pathological signs. It is, isn't it?
This is simply wrong. Okay, this is simply wrong. What you're suggesting is that a baby would have an infection that was so spectacularly rapid that the baby would die, despite having normal heart rate and all these other normal things, and where a pathologist found no evidence of infection on post-mortem. I mean, that's ridiculous.
No, Dewi, you're ridiculous. Because rapid onset sepsis can cause death without leaving signs on post-mortem. And one of the reasons for that, not specific to this ward, is what we call fulminant cytokine storm. Now remember, these cytokines, we have about 50 of them in our body, are little proteins that signal to different parts and from different parts of the immune system. And if they go haywire, they can cause death really quickly, but they won't leave any trace behind. The usual signs of infection are what are called neutrophilic infiltrates and necrosis, which is cell death. That's what you'll find when you look for infection at a post-mortem. But if the cytokines have overrun the immune system and caused it to go haywire, there won't have been time for those neutrophilic infiltrates and for those cell necrosis or apoptosis to actually occur. So it's ridiculous to say that postmortems are going to pick up every rapid sepsis. They're not. But don't forget now, we are talking about a unit that had biofilm, that's like biological plastic, left behind all over the place with Pseudomonas in it. And these non-functioning casters that are present in this baby or were present in this baby act as a nidus for biofilm formation. So this Pseudomonas biofilm on the caster surface can seed the bloodstream, causing bacteremia within hours. And we have the situation here where we've got multiple indwelling lines exponentially increasing that risk, because we have the UVC that left in and not removed, then a PICC line put in. And apart from the rapidity of the infection can also kill you by creating axotoxin. the bacteria will produce a poison that will kill you without leaving any trace behind. And biofilm-associated infections typically evade the typical or traditional inflammatory responses, which are going to further complicate any histological diagnoses that you're going to see for infection at post-mortem. And a lot of the biomarkers and particular things that you might be looking for at post-mortem, they degrade after death, and it depends what the length of time was between death and the actual post-mortem as to whether you're likely to find rapid onset sepsis as a cause of death. So the 4 good reasons that you might not see any sign of infection at post-mortem are the rapid progression, biofilm pathogens, immature immunity that causes blunted cellular response to infection, and antemortem antibiotics. If given antibiotics, you're going to have partially treated the infection, and that's not necessarily going to leave behind enough evidence to find at a post-mortem, even a very well done post-mortem. And bizarrely, on the other hand, I've done post-mortems on adults where we were looking for specific pathogens that we picked up in the blood and ended up not finding that pathogen at post-mortem, but finding a different pathogen. And again, that was likely down to the use of intravenous antibiotics. So it's ridiculous to say that all of this is set in stone. It isn't. So far from being ridiculous, as he says, it's clinically very plausible for a neonate. Multiple indwelling lines in a unit contaminated with Pseudomonas to succumb to rapid onset sepsis without definitive post-mortem signs. And I don't think you'll find anybody who has any experience in medicine who would disagree with that statement.
Okay. Can I just ask you to confirm this? In terms of blood sugar, can I ask you to confirm this? At times of blood sugar, in terms of blood sugar at the time of the collapse, are you able to assist us with what the reading was at that point?
No. Perhaps you can remind me, but
Well, we've seen there's a chart which has the blood sugar readings until we get to 2:15 that afternoon.
Yes.
After that point, Baby A received no fluid and no more blood sugar, did he?
We've been through that.
Yes. I'm sorry to delay you, Dr. Evans, but I wonder if you can help me with this. After that time, he received no fluid and no blood sugar, did he?
He received no fluid for 4 hours.
And no blood sugar?
No, he didn't have a blood sugar.
And we don't know what his blood sugar reading is at the time of his collapse, do we?
No.
Because no one has got it. So can you discount in those circumstances a deterioration linked to hypoglycemia?
Yes, I can.
Just so we can be clear, why do you say that?
Because hypoglycemia is pretty common in small babies, and they can be a bit jittery, they may have little fits. They don't just stop breathing on you. Well, because they don't. But if they did, they would respond pretty promptly to resuscitation, so yes. So, babies, yes. So there we are. So hypoglycemia is not a factor in causing this little baby's death.
Just so it's quite clear where we are, although you've dealt with this, the suggestion I make to you, Dr. Evans, is, from the available signs there, he was not stable, and he was not in a good condition at the time that he collapsed. You disagree with that?
I do. I heard the practicing doctor say earlier, they all used the word stable. Dr. Jairam did, Dr. Harkness did. I'm not sure about the others. But yes, they said he was stable. Looking at his markers here, apart from the tachypnea, we have markers of a stable baby, who, but for having an air embolus, would have survived.
That is what the practicing doctors have said. Do you accept everything they say?
Well, that's their opinion.
Did you apply an independent mind to what they say?
I have been pretty independently minded all my life.
I just wonder, you said about people not spreading news about the mistakes we make. Are you looking at this as critically at the people who've given care as you are at other elements?
Yes, I have actually. Yes.
Right.
Yes, I'm pretty independently minded.
Can I ask one other thing about signs or indications we have with Baby A just before I move on? And if it's something you can or you can't deal with, please say, Dr. Evans. A finding in the post-mortem which you're familiar with, Dr. Shukla, I don't mean you have it immediately to your fingertips. Do you want to remind yourself from the statement, it's a finding of congestion and hemorrhage at the time of the post-mortem?
Say that again. Have you got his...
It's page 724 in the statements.
Is this one of the J numbers?
It's an I number.
I don't think I've got that. I have seen the report, but I haven't. Last night. Tell me what you want me to answer, and I'll see. On the whole, if it's a pathology report, I'm more than happy to defer to the pathologist, okay?
I don't expect to raise something on the hoof with you like that, Dr. Evans. I don't mean that to be rude to you. If it's not something which you're turning your mind to, we can deal with it in due course if we need to. I'll deal with it that way, rather than ask you to form opinions as we go along.
If it's a pathology report, I would defer to a pathologist, and I know there is a pathologist in this trial.
There is.
And again, Dewi, you're talking crap, because we all know that hypoglycemia can cause death and be terminated even in the absence of overt or subtle clinical signs, particularly if the blood glucose levels are not monitored like this baby and treated promptly. Asymptomatic hypoglycemia in preterm babies is quite common. That's why you have to measure it. And the reason for that is that there are little or no counter-regulatory measures available to the baby. So the blood glucose just keeps floating down without any means of putting it back up again. And particularly neuroglycopenia, so that's a lack of blood sugar in the brain, which can then lead to very bad outcomes, like seizures at the last minute, coma, death. But studies show that prolonged hypoglycemia of more than 6 hours, which is perfectly possible in this case because we don't have the data to say it didn't happen, is strongly associated with very poor outcomes, including death. And we had a tacit admission there from Dewi Evans that there was no blood glucose. That's what Ben Myers said. There was no blood glucose going into this baby for 5.5 hours or nearly 6 hours, not 4 hours. And no dextrose administration at all during that time. Hypoglycemia can also cause cardiorespiratory collapse. We know that. And electrolyte imbalances. Again, hypomagnesia, hypokalemia, or low potassium, which are going to cause arrhythmia. And we know that these babies often show no signs. But we're not just talking about hypoglycemia, we're talking about the overlap of the sepsis, the RDS, which can mask signs of any other disease. And you're not going to find anything at post-mortem. So I think you've just waffled your way through this whole thing, that you've disregarded, downplayed every risk factor, and you've done exactly the opposite of what people would do in this situation. And I'll leave you a link to what's known as the Francis case, where a mother successfully sued because her baby died because of hypoglycemia that was mismanaged by a neonatal unit. So we not only have medical evidence to show that it can happen, we also have legal evidence to show it can happen. So just to finish off, let's just list the failings one more time in the care of baby A. So in no particular order, failure, that's the breach of trust. The breach would be no blood glucose measurement for over 5 hours. No dextrose administration despite known preterm hypoglycemic risk, meaning that the prolonged neuroglycopenia led to a clear present danger to baby. The standard of care should have been 1 to 3 hour glucose monitoring in all of these people. The breach regarding the catheter management, appalling. A malposition UVC left in line for 7 hours and a PICC line added without the removal of the UVC. The cause of that, from both risk would have been thought due to mechanical injury and stasis, exacerbated by hyperviscosity and maternal gain. Standard of care breach, immediate removal and position of malposition lines is mandatory. The breach interrupted IV fluids for 4 to 6 hours caused significant fluid deficit. 62 up to 180 mils. Who knows? Causing hemoconcentration at an elevated amount. Who knows? Because it wasn't causing a compounded risk of clot from FES and breaching the standard of care that requires 80 to 120 mils per kilogram per day of fluid to prevent dehydration in these babies. Breach, contamination by Pseudomonas, allowing the formation of biofilm-associated fat, and ignoring the standard of care that requires strict asepticity and environmental control in neonatal use. Breach, ignoring maternal antiphospholipid syndrome. No anticoagulant or heightened thrombosis monitoring, despite knowing that, causing a heightened risk for thrombosis formation, clear present danger to the baby, when we know that these babies need to be monitored for this. Breach, rising lactate, tachypnea, not addressed with escalating, leading to uncontrolled sepsis, metabolic acidosis, and multi-organ failure, ignoring the standard of care that requires an immediate sepsis workup and empiric antibiotic for expectant, clear and present risk to the baby. So the duty of care to that baby was breached on multiple levels, and the baby's death constitutes irreversible harm. So I doubt whether this case would survive a civil action, and I doubt whether anyone would attempt to defend it in a civil action. But you had used it there and used it as evidence to convict the nurse of murder. None of this makes any sense to me, and it never will. If that was my standard of practice, I would be ashamed of myself, and I wouldn't be seen dead working in a unit that allowed it to happen on a daily basis. So that's it. Maybe G will give me an idea for the next podcast, in which is, I'll see you then. Bye.